Hello, I'm Dr. Emna. I'll be your physician for today. So what's your name, madam?
Name is
Okay, so Miss Arij, how old are you?
68. Yep.
68. Are you married? Do you have kids?
I have four.
4 kids, okay. I suppose you already had your menopause?
For a long time.
Okay, so do you smoke? Do you drink alcohol? No
Nothing.
smoking and nothing. Okay. Were you ever followed at a cardiology consultation? Did you come to a cardiology consultation before? Do you have any cardiac disease?
Never. Never.
Nothing. Diabetes, hypertension?
I
Okay.
just take the
You have?
my sugar is elevated, but I don't follow any doctors.
Okay. Who told you this? Is it a general practitioner or a GP?
I thought the advice before some years ago. Actually, practice.
Okay, so they told you to see a nephrologist, but you didn't go to a nephrology consultant. Okay. Other than kidney disease, do you have any other history of cardiac disease in the family, the parents, the siblings?
So
No. Okay.
I my father has a problem.
Okay. Do you have any other? What is your current complaint?
I have time and breathing. I
Mhm.
and
And since when do you have these symptoms? Okay. So do you have any other symptom? Do you have chest pain? Do you have palpitations? Do you feel your heart beating?
chest pain. No,
Okay. Did you lose consciousness before?
what?
Did you lose consciousness before?
No, no,
Never.
never.
And this symptomatology started these few months, but you didn't get that symptomatology before.
Yes, but
Okay.
but I not sought medical advice before, and last month increased this difficulty of breathing. So I want sought medical advice.
Okay. Do you have more difficulties breathing at night? How many pillows do you use to sleep?
Yes, I can't sleep at night because difficulty breathing.
Okay. You don't have any other symptoms. You don't easily bruise. Your hand doesn't hurt or isn't numb when you use it.
Yeah, yeah, yeah. Even I'm housewife. When I work at kitchen or cooking or uh, anything
You
in
have troubles using your hand.
yes, I have more pain in my hand, like
Okay.
now
And you didn't
pain.
take any medications before. You didn't take medications before for this dyspnea. You didn't take something that made it better or that made it worse. Okay. I think we should. Okay. Okay. Miss Miss Arish, I will be examining you. We'll run at some lab tests. Maybe we'll need some other investigations. We'll be seeing according to the lab tests and to the EKG, so that we could see your heartbeat to see if there is any cardiac condition that could explain your symptoms. and I will be telling you after the investigations about what we found. Okay?
Okay. It will take time before
It.
it will take time because I'm
Not really. We will see. According to the EKG and to the lab investigations, we'll tell you what we should do next. We will probably do an echocardiography just to check for the dyspnea, and then I'll let you know if you will need any other investigations. Okay? But I'll let you know step by step. I'll let you know.
thank you,
Okay.
doctor.
Today's hard marked in systemic disease. Dr. Dr. Amna? I couldn't hear Dr. Arija's responses in the video. It was very difficult. Can you hear them? Could
Okay,
you hear them? Because I couldn't.
No, and I thought the problem was with the problem was with the internet connection, but yeah, I think. But I think it will be clearer in the presentation, in the case presentation.
Right.
Should we start our
Just
case
one
presentation?
comment. They always ask about cat chewing. So since Madam Irij is from Yemen, you should have put in the cat chewing bit. They always ask, are you a cat chewer? Are you a cat chewer? So she's Yemenis. Okay. All right.
Noor will answer, or if Noor will answer, or we will discuss about this together.
I think for me, I think it's B.
So Yemen team is B.
Who is okay for the first proposition, female gender? Is it the case? Is there any difference between the two genders, Emma?
I think C.
I'll be showing it on the references. The right answer was B, coexistent chronic or infectious disease. For the third answer, it's usually family history of ATTR amyloidosis, because it's a genetic mutation that could go from an ascendant to a descendant. This is the European Society of Cardiology guidelines. It's not actually a guideline, it's a position paper on amyloidosis, a focus on amyloidosis on 2021 that states that advanced age, male gender, black race, coexistent chronic or infectious disease, may be risk factors for amyloidosis. I don't know what you think, Dr. Hamimi. I want to see your I want to see the videos, but
Just a note on that. Did you know that 1 out of 6 people in the Mediterranean region, 1 out of every 6 people has familial Mediterranean fever surrounding the Mediterranean Sea? 1 out of every 6 people are carriers.
I can't hear you very well, Doctor. 6 people on?
1 of 6 people
1 out of 6
are carriers for FMF in the Mediterranean region. So one of the chronic diseases, and hereditary as well.
Yes.
And the Mediterranean fever is it's a risk factor for amyloidosis.
It's a complication. It's a chronic inflammation. Go on.
Yes, it's a chronic disease that could result in amyloidosis.
Okay. So when it comes to
for the third,
familial Mediterranean fever, it's a genetic deficiency. I think gene 6 or something
for
like
the
that.
genetic,
and Yeah.
It's usually not
It's a chronic.
genetic. It's usually the TTR amyloidosis, and not the EL amyloidosis. The EL amyloidosis is connected to myeloma. Okay?
Yes.
That's why the third proposition is not true.
Yes.
And the transmission of TTR amyloidosis, is it autosomic dominant, or what's about the transmission?
I should check that. I'm not sure. I should check that. I'm not sure.
Okay. You will check.
I want to go on. Can you see my screen moving? Okay, I think it's okay.
Yes.
So for the next question, what do you think regarding the pathophysiological mechanisms? Is AL amyloidosis caused by a genetic mutation? I guess we've already answered that. Do you think that ATTR amyloidosis is caused by the deposition of immunoglobulin light chains? Or are both types caused by an extracellular deposit of fibrils, amyloid fibrils?
So I think we answered the first proposition, and we said it's
Yes.
the ETTR amyloidosis, which is caused by a genetic mutation. The second proposition, it's proposition which is correlated with EL amyloidosis. And so the two types are caused by an extracellular deposit of fibrils.
Yes, exactly. They are both caused by an extracellular deposition of amyloid fibrils, but it's amyloid fibrils, but not the same type, and that's why we might have some pathognomonic manifestations, extracardiac manifestations when it comes to AL amyloidosis or to ATTR amyloidosis, because it's not exactly the same type of fibrils. So that was right. For the first question, which of the following evokes AL amyloidosis rather than ATTR form? Do you think it's periorbital purpura, carpal tunnel, or orthostatic hypotension?
It's A normally.
So it's B.
Difficult
What does the Yemeni
proposition.
PD.
What do you think, Dr. Hamimi?
So just for the third one, it's related to I think to the ETTR.
Yes.
Also the carpal tunnel.
Yes.
And the first one, it's rather, I think, the periorbital
More AL
purpura.
amyloidosis. Yes. So this is what I was talking about, and I think this paper is really interesting. It's a 2023 ACC expert consensus regarding the cardiac amyloidosis. There are some pathognomonic extracardiac manifestations of AL amyloidosis, like macroglosia, periorbital purpura, that is due to capillary fragility and acquired factor X deficiency. Musculoskeletal manifestations are more related to the ATTR amyloidosis. I keep moving the video screens because I want to see you. So regarding the monoclonal protein screening in amyloidosis, so the test that we ran, do you think that when serum free light chain assay, serum and urine immunofixation electrophoresis are all negative, we can rule out AL amyloidosis? Do you think that when we have elevated serum free light chain ratio, kappa lambda, it should be enough for the diagnosis of AL amyloidosis if we have a left ventricular hypertrophy in echocardiography? Or do you think that elevated serum free light chain ratio, kappa lambda, are pathognomonic of AL amyloidosis? What do you think?
A.
Yemen team?
C.
The first one is not true, I think. The first one is not true. It cannot rule out aryl amyloidosis. I think the third one is true. No?
Okay. Should we go on? The first one is actually true, and I will show you the reference on the ACC 2023 expert consensus when it comes to amyloidosis. Elevated serum free light chains ratio of kappa lambda can be found in chronic kidney disease, which could explain the fact that it could be associated to left ventricular hypertrophy, even when it's massive. If you ever have an uncontrolled hypertension in hemodialysis patients, etc., they are not pathognomic of AL amyloidosis, and the consensus expert tells us, as you can see underlined, that if all of these investigations are negative, the serum investigations and the urine investigations, both of them are negative, we can rule out AL. But I understand why you said that, Dr. Hamimi, because usually the search and diagnosis is with the biopsy. When we have a biopsy of for example, the cardiac biopsy, something that we don't do, but the biopsy of the organ that is affected and that is negative. That's the search to diagnosis. So I understand why you said that it shouldn't be true. So as you can see here, in chronic kidney disease, there are elevated serum-free light chains ratios of kappa lambda. They are quite common, but with a normal urine serum and urine immunofixation. So we should always do the immunofixation, not only the ratios. So fifth questions. Regarding the treatment, do you think that tafamidis is used in AL amyloidosis? SGLT2 inhibitors are not recommended, or ACE inhibitors are well tolerated?
ACE inhibitor.
A. A. It's A.
A for the ETTR.
Yes, tafamidis is for the ATTR. So we'll see Yemeni team. So we've ruled out A.
The third one.
C. C.
Third one.
C.
Okay, C for the Yemeni team. What do you think, Dr. Hamdi?
C as well.
C.
For me, it's B. She doesn't have a HbA.
Yes. In the ICC, in the same expert consensus, and these two papers are really excellent. The ICC consensus paper and the ESC focus on the amyloidosis of 2021. As maybe I should have put it in another way now that I'm reading it, because even in the heart failure with reduced ejection fraction, the SGLT2 inhibitors, it's not that they are not recommended, it's that we don't have enough data regarding it. So we'll be using it, but we don't know if that's effective in amyloidosis and heart failure or not, preserved or reduced ejection fraction. As you can see, RNAs and ACE inhibitors and ARBs may worsen the restrictive physiology. So they're not always well tolerated. They are sometimes, or most of the times, not well tolerated. So again, as you see, SGLT2 inhibitors have a theoretical benefit, but we don't have sufficient evidence regarding the efficacy or the harm in cardiac amyloidosis. Maybe in the case submission later for the book, I should reformulate the proposition. So last question. This is an easy one. There is a common association, well known, between amyloidosis and valvulopathy. So, do you think valvular disease? Do you think it's aortic valve regurgitation, aortic valve stenosis, or mitral regurgitation?
Aortic stenosis.
Are you Yemeni team? Do you agree? I don't think you could disagree with Dr. Hamidi. You agree? Okay, so that's it. Easy one. Aortic valve stenosis. 16% of patients with aortic stenosis have ATTR amyloidosis, cardiomyopathy. So we should always look for such an association. Maybe we'll see it later in the case analysis and in the consulting in the patient consulting counseling, but I'm not sure about the treatment options we have. The patient has heart failure with preserved ejection fraction, so there's no interest of ACE inhibitors, beta blockers, ARBs, RNAs, etc. SGLT2 inhibitors, we ended up giving her SGLT2 inhibitors, but we're not quite sure of what would that do to our patient's cardiomyopathy. The only thing we could offer is the treatment for her myeloma, because I think I skipped the slide, because our patient had myeloma, so we sent her to a hematologist. So except the treatment for the myeloma, the chemotherapy, and the SGLT2 inhibitors, we didn't have much treatment options. So let me know what you think, and I hope it was instructive.
That was a very interesting case, and a quick revision of all the amyloidosis. It's very, very interesting and very informative. And you will actually see cases like this often.
Yes. We have some centers that are quite centered on amyloidosis, or the big capital centers, the university hospitals. We see amyloidosis. This was a case that I saw in my in the original hospital where I used to work. In my hospital, it's a regional hospital. We don't have access to investigations, MRI, etc. So maybe it's quite underdiagnosed in regional hospitals and local hospitals, but we see more of them, more and more of them.
I think in Egypt as well, it's underdiagnosed. Dr. Rania, do you have anything to say? Comment on her?
Yes, congratulations for this nice case, and especially for the question. It was a very hard question for me, especially. And I learned a lot, really a lot. And thank you for the update, because you used recent guidelines, the recent update of the ECC. Unfortunately, as she said, in our country, it's the amyloidosis is underdiagnosed, and really we don't have tafamidis. I don't know if in Egypt there is tafamidis, and in Yemen.
Yeah, it's very costly.
No.
Diagnosis
What
very
I know
costly.
that it's very expensive treatment, and
Maybe the diagnosis is very costly.
Not very cost.
Even just to diagnose it is costly, not just the treatment.
But I have just one question for this patient.
Amna?
You said that there is no apical discordance or gradient of the strain rate. So, have you any comments about this finding? Is it pathognomonic when we found that there is a gradient of the strain? Is it specific of ATTR or ALE? What do you think?
Not that I know of when it comes to apical to the strain pattern, but there is a ratio, the apical basal ratio. There is a ratio that could be calculated, not just on the bull eye, but just to say if it evokes amyloidosis or not. I'm not sure if that's correlated to any type of them.
Okay, and another question. Would you prescribe beta blocker in this patient if she has heart failure symptoms?
She has preserved ejection fraction. She doesn't have any coronary disease. I think it will worsen her state. I'm not sure.
I think it's even contraindicated to put a patient with amyloidosis under beta blockers.
Yes,
because it will result in condition.
And she has the first degree
anomalies.
heart block. She has the first degree heart block on the ECG.
Yes.
So I don't.
Yes.
I think it's even contraindicated, as you said.
Yes, we should avoid to put them under beta blockers. And for the investigation, for the scintigraphy, for the myocardial, for the scintigraphy, did you perform scintigraphy?
Did we
perform scintigraphy?
Yes. I think I skipped the slide, as I said. I think I skipped the slide of the scintigraphy because that's when we discovered the myeloma and we sent her to the hematologist. I think I skipped the slide. I should have put it. I should put it on in the case submission for the book later.
And when there is no fixation, cardiac fixation, it's rather in favor of ATTR or EL amyloidosis?
The ATTR. When there is a cardiac fixation,
the opposite. If you have no fixation in the scintigraphy.
Yes, if we have no fixation, it's the AL. If we have fixation, it's more the ATTR. Yes. There's quite a nice algorithm. I think you're all familiar with. When should we perform the biopsies? When is it in favor of? So the serum tests and the urine tests are in favor of AL. And when we don't have a fixation, it's in favor of AL. When we have a fixation on the scintigraphy, it's the ATTR. So the serum for the AL, the scintigraphy for the ATTR. And of course, it's better when we have the biopsies. We usually do the salivary glands biopsies. This patient had a salivary gland biopsy, and we have the amyloid deposits. But the biopsy can't tell us, on the first exam of the biopsy, we can't know at first. We should do other testings to know if it's ATTR or it's AL.
Yes, I think your patient had a slight elevation of troponin level, no?
Yes.
And I think it's a bad prognosis factor when we get elevation of troponin.
Yes, the heart failure and the troponin levels.
Yes, and I don't know when you get a look on the recent guidelines, is there any recommendation to go into further investigation about coronary involvement if you get troponin elevation, or you should respect this? Because usually I get some question about that. They receive in hematology patient with suspicion of amyloidosis with elevation of troponin, and they asked if we should put patient under antithrombotic, especially if there is any other risk factors like diabetes, like hypertension. Should we investigate patient for this coronaries? I don't know. Do you have any idea about this?
It's not really precise. I don't remember that it's precise. And it's true that most of the time, or sometimes these patients are admitted to the hospital because they come with a heart failure, acute heart failure, and we have some high troponin levels, so we think of coronary, and they're admitted to the hospital. And later, when we do the echocardiography, so they usually end up having their coronarography, but there is no it's not specified on the guideline. Should we do it? Certainly, if a patient is symptomatic, I think we would do it. I think that if we have really high troponin levels, maybe we should do it as well. But to be honest, it's not mentioned in the guidelines like criteria or algorithms.
Yes. Also, I think the elevation of troponin could be explained by the renal failure, the slight renal failure.
Yes.
And really, we should be attentive if we decide to go into further investigation, especially coronarography, because I think your patient had myeloma with renal involvement. And when we will use contrast product, we can get nephrotoxicity, of severe nephrotoxicity, and even the need to go into dialysis. So we should be careful.
I think it's the same question that we sometimes have when we have patients with HCM, hypertrophic cardiomyopathy, and they have sometimes the intramyocardial, the artery in the myocardium. So they come with with the chest pain and some elevated troponin levels, and we know that they have HCM, but we always end up doing the coronarography. But for this patient, as you said, it's quite peculiar. She has the renal failure, the heart failure, the myeloma. She's too fragile for that. We didn't end up doing a coronarography for this patient, to be honest. So I couldn't say if she had coronary lesions or not, but we didn't end up doing it for her because we had stable troponin levels. I'm happy we're doing this by internet. Okay. So good morning, Mrs. Arish. Today I will be telling you about the results of the tests. So as I told you, we did the EKG to see heartbeats. We did the echocardiography and the MRI to see the cardiac muscle. And we did some lab tests and the biopsy of the accessory glands, the biopsy that you did in your lip. And we discovered that you have something that we call cardiac amyloidosis.
What's that mean, cardiac amyloidosis?
Okay, it's a cardiac disease. It's caused by proteins that are produced by abnormal cells, abnormal blood cells in your case. And these proteins that are not supposed to be here, they go and they settle in the cardiac muscle, in the kidney, and so they caused the renal failure that you have. They cause the dyspnea that you have because the muscle is so thick right now, and it causes heart failure with preserved ejection fraction. That means the heart can still pump the blood well, but it can't relax. So that's what heart failure with preserved ejection fraction is. It's caused by, in your case, by a myeloma. It's abnormal blood cells that produce these proteins, as I told you. Usually, patients are referred to hematologists, so that we'll be referring you to hematologists, blood doctors.
That means I have a cardiac disease?
Yes, it's a cardiac disease. It's a systemic disease. It's cardiac disease, renal disease. I know it's a lot to take especially after the exhausting tests you went through. I know it's a lot to process. Feel free to ask me any question anytime, now or in any other consultation. Unfortunately, we as cardiologists, we can't offer too much as therapeutic options or treatments. We will be giving you some diuretics to help you with the dyspnea, and that will probably help you get back to your usual lifestyle. But the essential treatment will be the treatment of the cause, which means the myeloma. It's chemotherapy usually.
Chemotherapy? What cancer?
Myeloma is a type of blood cancer. It's it has a better prognosis than other cancers, than most of the other cancers, but it's a type of blood cancer, and the treatment, as I told you, is chemotherapy. That's why we'll be referring you to a hematologist. For cardiac disease, we'll just be following your cardiac ejection fraction, your cardiac function, with the echocardiographies.
That mean I follow you?
What?
I follow you as a cardiologist?
Yeah, we'll be following you in cardiology consultation. We'll be following you to see if there are any other symptoms, to see if there's anything that we could offer. For the moment, as I told you, most of the molecules we're not supposed to give them to you, particularly because you don't have high blood pressure. You have quite a low blood pressure. You don't have a high heart rate. So we can give you beta blockers and ACE and so on and so forth. We'll be giving you diuretics, and we'll be giving you SGLT2 inhibitors to help you, as I told you, with the congestion, with the dyspnea, etc. But again, the main treatment is the treatment of the myeloma.
For how long I will take this medication?
Well, it's a long-term treatment. And well, excuse
Long
me.
life?
Yes, and we'll be adjusting the treatment according to the ejection fraction, because we'll be, as I told you, we'll be following your ejection fraction through the years. For chemotherapy, that's usually done by hematologists. It depends on the case. The hematologist will be telling you for how much time will you be receiving the chemotherapy, and for how much time you will be how many months will you be seen by a hematologist. But it's a lifelong disease. It's a chronic disease.
When I should visit hematologist?
We will transfer you right away. We will refer you right away. You should do that as soon as possible. I don't know if you have any questions or.
You think I need operation or and just medication?
No, there is no need for any operation or any intervention right now. It's just pills and medications, pharmacological therapy mainly. But you should be followed by a cardiologist and a hematologist. You should visit us whenever there are new symptoms or anything new, palpitations, chest pain, syncope, if you lose consciousness.
When I have in my hand, that's related to my disease?
Yes, that's related to the amyloidosis. As I told you, these proteins, they go and they settle in a lot of places, in the tongue, in the heart, in the hands. And as I explained before, we'll be sending you to a rheumatologist as well to take care of that. I don't know if you have any other questions. I don't know if you would like to share how you feel about it.
Thank you. So I will and
I'm available if you ever have any question, or if you ever want to discuss this again. And hopefully with the chemotherapy, we will be able to stop the disease, to stop it from going on and so on. Okay. Okay.
doctor.
Yes,
Now our
yes,
now our screen, how is it? It's clear.
yes, we can see your screen.
Now it's moving.
Just
Moving.
press on the slides. Click on the slides.
Okay. Now the you'll come. How are you? this case, a 68 years old female, menopause, and non-smoker who was complaining of fatigue, dyspnea, NIHA class 3, and BND over the past 6 months. Her past medical history was significant for chronic high creatinine levels and significant for recently diagnosed multiple myeloma. Clinical examination, patient is overweight, body mass index 27 kg with ecchymosis at right upper limb. Regarding the diagnostic workup, initial workup revealed she is anemic and overweight with impaired renal function test, GFR 45 ml per minute with ecchymosis and bleeding due to the thrombocytopenia. All of these findings are going with multiple myeloma, and we confirmed the diagnosis by immunofixation electrophoresis that also confirmed the presence of serum free light chain and by serum protein electrophoresis, which identify the M protein, which is called the Jones-Benz protein. Multiple myeloma is a hematological malignancy that is characterized by proliferation of the monoclonal plasma cells in the bone marrow, as we know. There is abnormal serum free light chain assay by serum and urine protein electrophoresis and the presence of proteinuria. There was elevated brain natriuretic peptide, which is a marker of cardiac stress and dysfunction. The ECG show low voltage QRS complex in addition to the first degree heart block. The echocardiography shows concentric symmetrical ventricular hypertrophy and preserves systolic function, and the systolic dysfunction consists with cardiac amyloidosis. The further testing confirmed the diagnosis of cardiac immunoglobulin light chain amyloidosis with high lambda and low and the cardiac MRI confirmed the echo finding and demonstrated subendocardial late gadolinium enhancement. The tissue biopsy, such as accessory salivary gland biopsy, was done and revealed amyloid deposits. The diagnosis based on the patient presentation and the diagnostic finding, the patient was diagnosed as a case of multiple myeloma and systemic amyloidosis with cardiac involvement, which is called AL amyloidosis. We have diagnosed this patient according to the last guidelines, according to the immunoglobulin light chain amyloidosis 2024 update on the diagnosis, prognosis, and the treatment. We found, according to this table, many criteria is going with the AL amyloidosis, such as the diastolic dysfunction, which is called the heart failure with preserved ejection fraction, the presence of the proteinuria also, the Berbera, and the history of carpal tunnel syndrome. The diagnosis of AL amyloidosis should be suspected in any patient with non-diabetic nephrotic syndrome, HIF, heart failure with preserved ejection fraction, non-ischemic cardiomyopathy with hypertrophy on the echocardiography, hepatomegaly or increased alkaline phosphatase value with no imaging abnormalities of the liver, chronic inflammatory demyelinating polyneuropathy with monoclonal protein or the presence of the monoclonal gammopathy diagnosed as MGUS or simulating myeloma in the patient with unexplained fatigue, edema, weight loss, or paresthesia. The cardiac amyloidosis is a serious condition with a poor prognosis, especially when the heart is the predominant site of the involvement. Early recognition of this condition is crucial as it may guide appropriate evaluation and the consideration of advanced therapies such as cardiac transplantation in eligible patients. This case has typical presentation of cardiac amyloidosis, which includes the progressive heart failure symptoms, low voltage on the ECG and the characteristic echo and MRI finding. The diagnosis is confirmed with the tissue biopsy, which demonstrate amyloid deposition. This case highlighted the importance of the recognizing cardiac amyloidosis as a potential complication in patients with multiple myeloma. The coexistence of these two conditions, the multiple myeloma and the amyloidosis, can lead to a more aggressive disease course and poor prognosis. Early diagnosis is crucial as it is allowed for prompt for initiation of targeted therapies for both multiple myeloma and amyloidosis. Treatment typically involves combination of chemotherapy, immunomodulatory agents, and supportive cardiac care. And as we mentioned, we used this guideline for the diagnosis, prognosis, and the treatment, the last guidelines. So we informed the patient and her family about the poor prognosis associated with cardiac amyloidosis. The patient and her family opted for the chemotherapy, which was started after consultation of hematologist. The treatment of multiple myeloma was initiated aiming to rapidly reducing the production of the amyloid genetic light chain. The management of multiple myeloma with AL amyloidosis the treatment, we used the following strategy that reflected the last guidelines and update. Firstly, the chemotherapy regimens, we used a combination of protease inhibitors, which is called bortezomib, and an immunomodulatory drugs, lenalidomide with dexamethasone, because these agents have shown efficacy in reducing both myeloma, amyloid burden. We started with the bolus doses, then maintenance doses as after consultation of hematologist doctor. Novel agents as daratumumab, a monoclonal antibodies, was used for its effectiveness in both multiple myeloma and amyloidosis. We adjusted also the dose, as we mentioned, the patient has creatinine, her creatinine was high. We adjusted the dose based on the renal function. We adjusted fluid and the medication doses based on the renal function to prevent further deterioration. And we considered the renal sparing therapies such as bortezomib based regimens, as they have been shown to improve renal impairment. The supportive cardiac care was initiated to manage symptoms and prevent further deterioration by the following treatment: diuretic therapy for volume overload and heart failure, ACE inhibitors for blood pressure control and to improve the heart failure. Regarding the follow-up of this patient, unfortunately, despite initial improvement, the patient cardiac function gradually deteriorated, and she developed refractory heart failure, and she passed away 5 months after the initial diagnosis due to complication of the cardiac amyloidosis. Regarding the prognosis of multiple myeloma and the amyloidosis, the prognosis is generally poor, with the median survival of only 12 to 18 months. Factors like the extent of the cardiac involvement, response to the myeloma treatment, and the development of the other organ dysfunction can further affect the prognosis. 2021 study in the journal Amyloid found that lower body mass index, less than 20 kg per square meter, has associated with worse survival outcomes in AL, and the higher body mass index was linked to improve the biomarkers and organ response rates in both AL amyloidosis or multiple myeloma. A higher body mass index more than 30 or equal than 30 kg has significant better overall survival compared to those with normal body mass index. The EHA and ISA guidelines advise to avoid significant weight loss, as it can negatively impact prognosis and treatment tolerance. And the survival benefit associated with higher body mass index and the nutrition optimization should be part of supportive care in the multiple myeloma. Elevated BNP and troponin levels indicate worse prognosis in patients with AL amyloidosis, and higher levels are particularly useful for monitoring treatment response and disease progression. In conclusion, the cardiac amyloidosis is a rare but serious complication that can occur in a subject of multiple myeloma patient. Amyloid light chain Amyloidosis is the most common type and the result from the deposition of the immunoglobulins light chain produced by the clonal plasma cells. To take home message, early recognition and aggressive management of both multiple myeloma and AL amyloidosis are crucial to optimize outcome. Cardiac symptoms may precede the diagnosis of multiple myeloma, so a high index of suspicion is required. The primary goal of aggressive treatment of the underlying multiple myeloma is to rapidly reduce the production of amyelogenic light chain by treating the multiple myeloma. A comprehensive management of cardiac amyloidosis includes supportive medication and the novel medication targeting amyloid deposition. Thank you.
Okay, thank you, Dr. Sumaya. Your case analysis are starting to look more and more like case analysis for real, which is there. Your PowerPoints are looking sharper. I see improvement. We're getting there. Inshallah, bismillah. Dr. Arani, what did you think? Okay. Is there a sole presentation? Dr. Abdul Hamid, is he there?
Yes, Dr. Abdul Hamid, no.
Is he there? Okay.
Yes, it's still
Can
there.
we go to the
Yes, I'm
debriefing
here.
first? Really fast? How long do we have?
Yes,
Yes.
just a minute.
Okay. Let's debrief while he's getting ready, okay? Do the debriefing while he's getting ready.
Okay. Briefing دحين. هذا حقك صح؟ هذا حقك بايوكيميكالز.
لا مش حقيقي كده صديقي.
البايوكيميكالز.
ايه لا مش الفيديو لا عندي البايثون ميثودز يمكن لا مش عندي. يس
Can you do the debriefing as Dr. Abdul Hamid gets ready? He's ready. Okay.
Yes, okay. Good morning.
Yes.
لا.
Okay, we're running out of time, so we have 10 minutes. 9 minutes. Is that enough, Dr. Abdul Hamid? Will you finish before 9 minutes?
Yes, okay.
Okay,
inshallah. Small يعني I have
Dr. Abdul Hamid, how long is your
Little.
presentation?
it's little I think it's about Beaton's methods Dr. Beaton
More than-
methods study.
Is it more than 5 minutes?
Yes.
Will you take, it will take more than 5 minutes?
أقل من 5 minutes يعني. Less than approximately.
Okay.
Good afternoon, doctors. I'd like to speak about Beaton's methods. The introduction: graduate nursing and medical students should know how to perform some basic skill. Different methodologies for learning skills and a catalog of knowledge and skills and batons for steps. How to learn skill. simulated patients, videos, mannequins, computers, and virtual reality technology are increasingly being used to ensure that teens learn skills in safe environment and receive feedback and reach certain level of competence before they use the skills on patients. The first training year is critical for learning many of these skills. Skill centers are playing an increasing role that laboratory learned skills are safely implemented in the workplace. Our teaching role is to decide whether students can safely carry out procedure on patient. Simulation possibility, simulated patients, video material, virtual patient and computer programs, and mannequins. Advantage of simulations: safe environment, feedback, achieving competencies before working with real patients. Students are actively involved in process. Perform skills: it is not only important to perform, but knowledge, indication, contraindication, and skills and communication with patient. A Beaton's methods approach 4 steps. Beaton methodology disintegrate studying process on the manageable steps. Students must explain what they are doing, provide possibility for repeating, and provide possibility for correction of mistakes. The Beaton's methods spirals on 4 steps: demonstration, deconstruction, comprehension, performance. Structure of the session, main element, dialogue, and the session. Main elements of the session: clear learning outputs after session, realistic in time, output relevant and important for students, explained on adequate level, is space for learning adequate, good estimation of previous knowledge, position of students, compare with trainer and etc. Dialogue: 10 or 5 minutes, 10 until 5 minutes. Eye contact with the students. Is procedure disintegrate on the enough number of steps? Is task too long to accepted during one session? Did trainer give proper positive comments? End of the session. Our students are capable to perform skill individually without help. Do they get suggestion how to perform skill in different circumference? Do they get summary with this message in the end? Useful literature and links for independent students. Take message home. Python 4-stage approach. Demonstrate normal speed, no explanation. With the second one, with the explanation of each step, allow questions. You do, learners explain. You questions, learner does, and learner explain. Thank you.
That was very fast and very informative, and I think you covered everything about Peyton's method. We're about to be cut off, so can we do the debriefing really fast? get to the debriefing. It was very nice, Dr. Abdul Hamid. Can we do the debriefing really quick before we're cut off? We have like 3 minutes left. Quickly do the debriefing.
I think our team can do the debriefing since we are the team that prepared the case. So that leaves only one team.
Okay. Is Dr. Rania here? Is she still? Okay. Okay. So thank you everyone for today. And please hand in your assignments on time so I can give them to the professors because they don't get the assignments on time. So they don't get a chance to review your cases, which is really important. So that you can open greater discussion, room for better discussion when we know what's coming up. Okay, so try to hand in your cases earlier. Your case submissions, Dr. Amna, Dr. Noor, you can hand in your case submission for today as well. Work on it, hand it in so we can give it to Dr. Rania and Dr. Gamila. That was very nice. I hope we can continue these sessions. I hope we can do something about this live transmission. It's driving me crazy. I'm going nuts with this transmission problem. Skype is a lot better, I think, if we can get into it.
Yes.
Dr. Rania is here?
Yes, I am here. So
Okay.
thank you everybody also, and congratulations for this very interesting session and for the interesting cases.
Yes, they were very interesting
Hope that
today.
we see that cases published as well as we said in the beginning of this planning, because very many key messages and many learning aims, I think. Bravo tout le monde.
Hey, are we being cut off? Yes. Okay, so to wrap it up, hand in your cases, please, on time. And Dr. Rania, I'll be sending you their case submissions for peer review. Inshallah, bismillah, as soon as they give it to me, I'll give it to you right away. So we can start working on the publication of the book, inshallah, bismillah. Thank